Hi, good afternoon, everyone. Thank you for joining us for the Advanced Critical Care Echo teaching for this week. Absolute pleasure to welcome back to the stage Professor Tony McLean. Thanks, Prof, for coming to talk to us again about one of, I know it's one of your favorite topics, and it's an absolute cracker, this talk. Talking about sick, pregnant hearts. It's absolutely brilliant to have you back on. So thank you very much, Prof. Without much further ado, I'll hand over to you. Beauty.
All right, and thanks for that opportunity, Sam, to talk about a subject that obviously I think is a fascinating one, and obviously it's covers quite a lot, and the intensive care doctor comes across it from time to time, and it's hard to be on top of it all, but there are certain things that make it a little easier if you're doing intensive care, echocardiography, and dealing with hemodynamically unstable patients. And there's really two approaches to it, and one is antenatal assessment, and this of course is where the obstetrician is aware that the woman has some particular cardiac problem or potential cardiac problem, and will ask someone to see the patient, and they'll inevitably get an echo, and you go into it planned, and I have a few cases we'll come across that, we'll discuss that later. And the other, of course, is quite often the case in critical care medicine, is that the first thing you know about it is there's some sort of disastrous problem occurring around the time of the delivery. And this is the patient you may be aware they've had a cardiac problem, or alternatively, it might be completely out of left field. So the antenatal assessment, let's just deal with that so you realize that a lot of these patients are, in this day and age, are looked at very carefully before they, sometimes before they become pregnant, they know they have an underlying congenital heart condition, for example, and the questions raised, is it safe for this woman to have a baby, or would she be better off being convinced not to have a child because of the dangers? And there are a number of specific cardiac pathologies that we look for. The congenital ones that you see there are ones that you'll all be familiar with. Atrial septal defects, PDAs, coarctations, tetralogy, VSDs, etc. And on the hereditary side, you have ones that are coming through, and I guess the one we would see most commonly would be the bicuspid aortic valve, which may or may not have some functional abnormalities such as regurgitation or stenosis. Marfan's you do come across from time to time, but it's uncommon. Hypertrophic cardiomyopathy, unusual, you see it very marked in a woman in her 20s or 30s, but it is possible. There other, of course, is the valvular ones, and depending on which part of the country you live in, or which country you live in, valvular disease can be very important, because if rheumatic disease is quite common in your community, then you really have to keep an eye out for these patients, because often they're not diagnosed prior to their delivery. There's obviously non-rheumatic heart disease. There's mitral, it could be mitral, aortic most commonly, although you'll find that in the pregnant population, you still have a fair number with pulmonary or tricuspid problems, mainly congenital in origin. And cardiomyopathies may have been present for some years, or might just occur at the time of the pregnancy. And of course, don't forget coronary artery disease. A lot of women now are having their babies in their 30s, and in some of the high-risk populations, it's not, I wouldn't say it's usual, but it's not unseen. In 1 year, say at a hospital like Nepean, where we have about 5,000 deliveries per year, there'll be 1 or 2 with underlying documented coronary artery disease. The other pathologies are arrhythmias. Now, the arrhythmias are the tricky ones, because most of the time they're not a problem. They're non-ischemic, and they're usually secondary to other pathologies. SVT is very common. Atrial fibrillation, less so, and usually related to some other underlying problem. Ventricular ectopy, I must say, is one of the difficult ones, because although you can see it, you can measure how many VEBs, you can determine whether they're unifocal or multifocal. It's often very hard to get an understanding of whether in that particular woman it's a stable situation, or alternatively, if she's stressed, like during delivery, will that develop into a more malignant ventricular arrhythmia. And sometimes it's quite ill-defined, it's difficult to pick it up. And sometimes a lot of women feel they have palpitations, and when you look for it on Holter or whatever, you find that in fact they tend to have sinus tachycardia. So what's the mortality associated with each of these diseases in pregnancy? And you'll notice down the bottom, this is a pretty old reference now, because they were easier to tabulate in those days, where it's a lot different now because of the different surgeries that people have. We have a lot of people now who survive into adulthood and can have children, whereas in fact in 1995 that wasn't necessarily the case. But the chart is very helpful just to give you an idea that which ones you're really worried about. So let's just jump straight over to group 3, where in fact, without warning, if you've got pulmonary hypertension, coarctation with complications, or Marfan syndrome with aortic involvement, your mortality, though, in that time was 1/4 to 1/2 of the women would die. We'd like to believe these days with good antenatal care, if a woman persisted in having a pregnancy despite being attempted persuasion not to have it, then we would probably do things quite differently to what we would do then to ensure a better outcome. Going back to group 1, ASDs, VSDs, PDAs, corrected tetralogy, having a porcine valve, you can see, or mild mitral stenosis, these women shouldn't really get into too much trouble, but obviously would keep a close eye on them. It's the middle group that really we start taking more attention with these patients. Mitral stenosis in the presence of atrial fibrillation, that's telling you you've already got elevated left atrial pressures. If you have a mechanical valve, you've got the balance between anticoagulation and bleeding at the time of delivery. Mitral stenosis, a little like aortic stenosis, is if it's quite advanced, then of course the woman has no way of compensating. Should she bleed, or should she have some other hemodynamic compromise because she can't increase the cardiac output beyond a certain point? And you really wouldn't like to take on an uncorrected tetralogy or fellow. A previous MI these days, it's easier these days, and I'd put them into group 1, because if you've seen them and they've got a documented myocardial infarction, they would have had an angiogram, they would have had the lesions identified, the coronary artery lesions, they've normally had them stented, and so they often come to you with an angiogram that shows that really they're not really at any greater risk than those without coronary artery disease. Obviously, if they have multi-vessel disease and they have uncorrected stenosis, then that's a different story. So in everyday practice, congenital heart disease, it's uncommon, but it's generally known about. And it's always interesting to me that if the woman comes to see you beforehand, they almost, in 90% of cases, are accompanied by their mother, who knows all the ins and outs from over the last 25 odd years. Ischemic heart disease, usually known in advance. Valvular disease is the most frequently encountered one that concerns us. Arrhythmias are common, mostly benign. They're often very troublesome, and you often have to start medication, particularly towards the latter stages of pregnancy, because of the inability of the woman to cope. So if you were going to die from having a baby in Australia, this is a couple of years old, but it's no different to what it is now, is in fact in 2017, there were 16 maternal deaths across the country. So it's not particularly high. It means there's 6 maternal deaths per 100,000 women. So if you like our unit with 5,000 births per year, we would anticipate that we would have 1 maternal death about every 2 or 3 years, and we do. They are often deaths that are related to pregnancy, but that's only 19%. A lot are indirectly related to pregnancy. For example, if you had trauma and you died in a car accident and you're pregnant, it would be a maternal death, but it wouldn't be as a result of the pregnancy itself. You can see the cardiovascular is the main cause of maternal death, 5 out of the 16. Disturbingly, you see suicide is 4, and the others are not particularly high in this day and age. It really doesn't alter that much over the years. You could see that the maternal mortality remains about the same over the last 10 or 15 years. If you look at the number of deaths over a 10-year period, then they do start to add up, and you can see that over the 10-year period, that cardiovascular diseases, of which are over 20 were a result of the cause of death. Only a small number were direct. The others were probably a situation where a woman had another problem occur, but because of the underlying heart disease, couldn't cope with it as well as somebody who didn't have that lesion. But I just also like to point out that you really have to, from the intensive care viewpoint, if you're talking about the cardiovascular side of things, you really have to include the thromboembolic group in there as well, which also has 19 patients over 19 women over the 10 years, because that's the one that we would unexpectedly have arrive in our intensive care unit. And you can see, in fact, in that scenario, the great majority, all but one, are in fact directly related to the underlying thromboembolism. When do they occur? Well, most of them occur around the day of the birth. And you can see there that on the day of the birth, the most direct ones occur then. But don't be too blasé when the baby's delivered. They're in your intensive care for a day or two. You want to clear the bed, you want to get them out. Just remember that the maternal deaths still continue to be substantial in relative terms over the next couple of weeks. So it's not the day of the birth, it's day 1 to 6 and day 7 to 13. And as you can see, a lot of those are directly related to the underlying condition, of which the majority are cardiovascular. So let's get on to some cases, because it becomes rather interesting. Now, this is an antenatal care, but obstetricians would often ask the intensive care to get an idea about the patient prior to considering delivery. And this woman was transferred from Parkes. She had marked dyspnea. She was 33 over 40 weeks pregnant. She had had a number of pregnancies in the past, despite being relatively young. And there was an element here, it was pretty hard to pin down, but there appeared to be domestic violence that resulted in the loss of some of these pregnancies. The past history, though, was that she had congenital aortic stenosis, and it was a subaortic membrane as well as the aortic valve itself. And over the years, 2001, 2004, 2014, she'd undergone 3 sternotomies and for membrane resection and resection of the left ventricular muscle around the level of the subaortic region. So the patient was quite adamant that she had aortic stenosis. And so the question was, she was looked after very well in Parkes by a cardiologist in Orange at the time, and they knew all about her. But her symptoms were somewhat vague. She had some marked nausea. And of course, when she came to us, we did a TTE. This is her picture here. You can see in the top left-hand corner, you can see the aortic valve. You can see a broadening of the aortic root. I guess importantly, what we're looking for there is looking for any subaortic narrowing, keeping in mind that she did have an operation 5 years prior to that, the third operation to deal with the subaortic stenosis. But we couldn't, there was sort of a bit there, but it wasn't that impressive. And so when you look at the apical 3-chamber view, you can see, in fact, there's a degree of aortic regurgitation. It's very difficult to comment on the presence of, or otherwise, of obstruction around the valve. You can see the color M mode there to give you an idea that the aortic regurgitation is mild to moderate. It's certainly above 25%. And the important thing, though, that when you look at the Doppler across the aortic valve, you can see you've got a Doppler there of nearly 9 meters per second. So this rings alarm bells, because although when you look at the anatomical side of things, this is a very high velocity across the valve, which indicates that in fact she's got a significant obstruction, which we don't seem to be seeing. And with that history and being 33 weeks pregnant, you really need to sort that out before delivery is planned. And here we have here in the top left-hand corner, you can see that the maximum gradient is 45. So I said 9. In fact, the gradient across the valve is 3.37. And you can see that her ejection fraction is mentioned there. It's 50%. It's not too bad. And as shown here, you've got, this is in the subaortic area. She certainly has a velocity there of not about 2.6 meters per second. So it indicates there's quite a high velocity across the subaortic area. So the question is there a subaortic stenosis that we're not seeing? Now, this is very important because, in fact, she's going to have a baby. There's, the question is, how do we manage this? Because, in fact, the anesthetic the anaesthetist gives will depend very much on what we tell them about the valve. How does she manage fluid if she's got excessive bleeding? And they always ask, should we deliver her vaginally, or should, in fact, we do it by cesarean? So here we had a look at it again, and you can see that this is the aortic arch. And so what we did with the aortic arch is we thought, well, look, if there's an obstruction over the aortic valve and the subaortic region, then that velocity should reduce as it comes around the arch. But in fact, when you look at the arch, you can see, in fact, that the velocity is, in fact, exactly the same. It's 3 meters per second. So this moves the high velocity. Obviously, we readily jump to the Bernoulli equation, 4v squared, et cetera, but of course, the modified Bernoulli equation has a lot of caveats. And just because you have a high velocity doesn't mean to say you have an obstruction. And that's the situation here. There is no obstruction across the valve, but she does have a high velocity across the valve. And so if you look at her hemodynamics using echocardiography, you can look at the LVOT diameter, you can look at the VTI. She's got a cardiac output of 6.7 liters per minute, or an index of 4.1. So that's telling us, in fact, that there's no significant stenosis, there's no recurrence of the subaortic membrane. She's got a really high cardiac output to moderate and severe aortic regurgitation, in addition to pregnancy. So we could turn around and say with this lady that, in fact, don't worry about the aortic valve. She's got a good, healthy heart. She's doing okay. Now, just to think about that high velocity, just remember that your plasma volume reaches 40% above baseline at 24 weeks. It increases, your cardiac output increases 30 to 50% during pregnancy, and the early pregnancy mainly related to an increase in stroke volume. In later pregnancy, it's related to the increase in heart rate. Your heart rate starts to rise at 20 weeks, continues increase until 32 weeks, and it remains high for some time after that. Your blood pressure typically drops in pregnancy, and that's caused by active vasodilatation. And as a result of your plasma volume going up, your heart size can increase by up to 30% during pregnancy. This is just an example of what we'd do with this woman, though, because as you know, the death of a woman or a baby or an infant or fetus in this day and age is in many cases, a failure of dealing with it well. So we would have, just to give you an idea how we deal with this, we get together with the anaesthetist, the obstetrical physician, the cardiologist, the intensivist, and then we go through what the plan is from the first step, and then so we have it covered throughout the whole thing. And so in this case, as you can see, I'm not going to go through it all to say we would aim for vaginal delivery. There's no need why she should go for cesarean unless it was an urgent. And we wouldn't give her a spinal anesthetic, as you can see on number 8, because of a dramatic drop in blood pressure possible. And so this is just an example of how you would approach these women to make sure, hopefully, they would never come anywhere near the intensive care unit. Now, here's another case transferred from the Midwest. Because we have a neonatal intensive care unit and a high risk obstetrical unit, we have a lot of patients transferred to Nepean. This woman's a 25-year-old. She's only 25 weeks pregnant. She's markedly dyspneic. There's a history of antiphospholipid syndrome. She was sent to us, and that's her X-ray, and she was sent to us because of pneumonia, and the question is as to whether she would require intubation, and on the background, of course, was a pregnancy of 25 weeks. And you can see in that picture that, in fact, she has quite diffuse shadowing throughout both lung fields. The cardiac silhouette is large, but it is a AP film, so you've got to keep that in mind as well. This is her transthoracic echocardiogram. She's now in the intensive care unit. Query, should she actually have it be intubated? And you can see in the top left-hand corner there that in the apical 4 chamber view, that she really has a abnormality of the mitral valve. If you look at the mitral valve on the top right, you can see that the leaflets seem very thickened. On the bottom one there, you can see that there's a degree of mitral regurgitation. And if you measure the mean gradient across the mitral valve, you can see the gradient is 9.83, which means that she has stenosis, and in fact, that would put it into the moderate to severe mitral stenosis. So here we have a woman with whiteout of the lungs, history of antiphospholipid syndrome, sent to us for respiratory distress. And the first thing we pick up is, in fact, it's a mitral valve problem. And therefore, we would turn around and say it's most likely that the changes on the X-ray are not due to the pneumonia, but more likely due to the mitral valve lesion. This is a view here. I don't know. Oopsie. Obviously, they're not playing. But this is just to show you that we looked at if you pressure half time, the mitral valve area is 3.2. So you can see that's a discrepancy compared to the mean gradient across the valve, and I'm not going to go into this decision there. I have to say it doesn't look severe to me. I do believe it's probably more mild to moderate, just eyeballing it, and there's probably not much more to add there at all. Now there's once again, you can see, although they're very thickened leaflets, you can see that there's quite a space between the leaflets, although the valve's certainly not opening normally. The other thing that is important is that, in fact, the interatrial septum here is bowing towards the right-hand side, suggesting that she really has quite elevated pressures in the left atrium. This is just confirming what we know already, is that, in fact, when we look at there's mitral regurgitation present as well. We can see that both here and on the color here. And when we look at the lung ultrasound, which I'm imagining most of you do automatically in your respiratory failure patients in the ICU, you can see there's a plethora of B lines suggesting that she does have pulmonary edema. Now, we did a toe on this woman, and this is the toe. And you can see on the left-hand side here, we get a much better indication of the leaflets. And you can see, although we're all thinking vegetations, we're thinking sepsis, we're thinking that sort of thing, the vegetations are interesting because they tend to be rounded and they tend to wobble somewhat. They don't have that irregular edge that you get with septic vegetations. We're looking here to see if there's any fistula through the vegetation, but the mitral regurgitation appears to be entirely through the gap between the two leaflets. And so we're looking at something here, and I'm sure for some of you who have an idea that we're looking at something unusual here. And the differential diagnosis will be infective endocarditis. It could be marantic, non-bacterial endocarditis. Does she have some other problem that's causing this? Is it Libman sac endocarditis, which you get with SLE? but you also get it with antiphospholipid syndrome. Is it Lambrel's excrescences? Unlikely. They're fully formed little thread-like things. And is it a tumor? It would be unusual to get a tumor on your mitral valves, but in fact, it's a Libman sac endocarditis. And this is a picture of the Libman sac endocarditis. And as you can see, it's a sort of a waxy, rounded color that you get there in your valves. You can see there's sort of the yellowy, waxy look. And this makes for a very difficult situation in a case such as this woman, as I'll come on to in a moment. Non-bacterial, it does call us under the marantic, but it's the Libman sacs is sort of smooth or warty. They are along the lines of the valve closure. They tend to occur more on the mitral valve than on the aortic valve. And very importantly, they're also a very high embolic risk. So what did we do with this woman? Well, the important thing was with this woman is that, as I said, the trouble with the marantic vegetations is that if you wanted to remove them surgically, you can't, because unlike infectious vegetations, where the vegetation sits on the leaflet, marantic endocarditis, the vegetation, in fact, is a waxy thing that makes its way all into the leaflet, and the only way around it, in fact, is to replace the valve. And so the question was, in 25 weeks of age with this woman, should we do something about the valve, or do we try and ride it through, deliver the baby, and then in fact we deal with the valve afterwards? We adopted the latter approach. Obviously, there's a lot of discussion on the subject, and we felt that with anticoagulation and prednisone, we would hopefully stop the further development of the marantic vegetations. The marantic endocarditis, as it turns out, she delivered rapidly and unexpectedly at 28 weeks. And the long story was that the woman survived. She ultimately had the valve operated on about 6 months post-delivery, and the baby was well. So that's where you have some warning in the ICU as to what's happening, but sometimes, of course, you have no warning. And here's an example, a case study of someone with no warning. This is a 17-year-old, and she was a fascinating young woman, because in fact she turned up one day at 39 weeks. She had been previously asymptomatic. She had dropped in time to time to the antenatal clinic, but at no stage had she been unwell. But on this particular occasion, she'd been tachycardic and dyspneic for 24 hours. It was felt that she's 39 weeks. She was a small woman. She's only 17. She wasn't large at all. And it was felt that maybe she was just dealing with the latter parts of pregnancy. But it became apparent she was becoming hypoxic. And on top of that, there was marked fetal distress. So what happened was that, in fact, the woman was taken to surgery because of the fetus. And they felt they had to get the fetus out in a hurry. But in the operating theaters, in fact, it all fell apart. She was in the hospital only a few hours in the labor ward. She was transferred to the operating theaters as a matter of urgency because of the fetal distress. She was intubated because it was noted she was hypoxic. The second they intubated, they had pink frothy sputum come up through the tube. She remained hypoxic. And then her blood pressure on intubation fell to the floor, and she was markedly hypotensive. So the approach was they couldn't bring her oxygen up. They couldn't give her fluid for the blood pressure. She was on inotropes. And the other thing they did was deliver the baby very quickly and then transfer her to the ICU, and sort of came through the door in a hurry, telling us that we had to ring St. Vincent's Hospital and transfer the woman to St. Vincent's straight away because it's obviously she had a peripartum cardiomyopathy, and they pulled her through this, but she needs a heart transplant. And of course, often people rush to the most dramatic things first. This was at 6:30 in the evening, and we were there. And the first thing we did was do an echocardiogram. And she basically arrived. We did an echocardiogram, and straight away we could see what this woman's problem was. So within 30 seconds, and this is the beauty of echocardiography, is you could actually do something with this woman. And I'm sure those of you watching this can quickly appreciate that there's a big difference between the size of the aortic root and the left atrium, with the left atrium being very dilated. And when you look at the mitral valve, you have the hockey stick appearance of the anterior mitral leaflet. And in fact, from what we can see, the left ventricle seems to be contracting reasonably well. Here's a view here when we look at we're looking at the valve with a colored Doppler. You can see that there's a very narrow aperture here. There's a degree of mitral regurgitation as well. And the ventricle seems to be all right. So once again, it all comes down to a physical obstruction here in the mitral valve. This is a classical appearance. We couldn't help ourselves getting an MO with a classical appearance of the mitral stenosis with the loss of the E wave and the A wave, just the shape that we have here. And then with the apical four-chamber view, it confirmed our impression that we had a very large left atrium and increased left atrial pressures. And so straight away we knew with this woman, the answer was get rid of the fluid out of the lungs. That's why she was hypoxic. We looked at the left ventricle though, and here's the mitral valve with the short parasternal view. This is the size of the left atrium, which as you can see is 145 mil volume. The ejection fraction was normal, 56%, and this is actually a view of the tricuspid, which it doesn't look like, but she's got a obviously pulmonary hypertension. So what did we do? The immediate management was to diurese her. So the first thing we did, she was intubated, ventilated, hypotensive, hypoxic, and we just put her on two things that you do in this situation. You actually diurese her as quickly as you can. And number two, you try and maintain her in sinus rhythm. And I didn't mention it, but you would have seen in those echoes that she's in sinus rhythm. And you want to keep her in sinus rhythm because if she goes into atrial fibrillation, that may be sufficient to tip her over into cardiac arrest because, in fact, of the drop in cardiac output in somebody who's already hypoxic and who's hypertensive. We diuresed a number of liters off overnight. And obviously, this woman had got through her whole pregnancy and her previous life with quite marked mitral stenosis. It had not been picked up. And by the next morning, I'm happy to say we had her extubated. She was sitting up holding her baby. And I can remember there's a beautiful view of her sitting there with her baby and her mother there, the three generations of women smiling, chuckling over the baby. So that was a great sight. She didn't need a heart transplant. She didn't need all those fancy stuff. She just needed a diagnosis and an echo ASAP. The medium term, of course, is that she does need a valve replacement, and she had that she had it about 8 months following the pregnancy. Here's another example, another case here of a 26-year-old who had an elective cesarean section. It was she was actually G1 PO at the time. She was G1 P1, I guess, by the finish. She became markedly breathless during the procedure, and this woman was healthy. She had no medical problems. It was a beautiful anesthetic up until they opened the uterus to remove the baby. It was an elective C-spine, and then she basically dropped her blood pressure, became markedly hypoxic, and required CPR. The lady was transferred. It was in the middle of the night. She was transferred to us, CPR on the way from the ward, and in the ICU, this was the first thing that we did to do was to do an echo, and you could see that the writing was on the wall here, that this is the apical 4 chamber view. All these shots are done during CPR. The CPR, as you can imagine, in a previously fit, healthy woman continued for a while we tried every trick in the book. And you can see there that the right ventricle is dilated. You can see that there's paradoxical movement of the septum. You can see that the left atrium is collapsed and the left ventricular contraction is very poor. And you can see the bubbles are present in the right ventricle as well. This is it. This is the echocardiogram from the apical 4 chamber view. You can see the classical situation of a pulmonary embolus, and where you have gross dilatation of the right ventricle and the right atrium. It's a reminder that in the acute situation, you can dilate up your right chambers extremely rapidly. And with that dilatation, because you're enclosed in a pericardium that with limited expansion, you can see the subsequent reduction in the left side of the heart with a small left ventricle and a very small left atrium. We were never having seen it before. We believe that those masses in the left atrium are amniotic fluid embolus. That's what this woman had. She had an amniotic fluid embolus. It occurred at the time the baby was removed from the, and the placenta were removed from the uterus. And unfortunately, despite our best efforts, it was just impossible to resuscitate this woman. You don't see amniotic fluid embolus very commonly. It's very, very unusual. There's a lot of debate to say whether do you get milder versions of it. The chances are probably yes, but it's hard to tell. Diagnosis is extremely difficult, and in the situation like this, treatment options are also very limited, even in 2022. This is another one here. The ICU, because of Nepean, intensive care has a lot of interest in pregnancy-related problems. We're often called to deal with their emergencies. And this was Sam's patient actually, a 31-year-old post-cesarean, delivered twins, was on the way to recovery and had sudden shortness of breath, had a heart rate of 120 to 140, SATs were okay. Blood pressure, not too bad really for a pregnant woman. Given some fluid. You've got to be very cautious about giving fluid, of course, because I'd rather do an echo first. You might find she was already in pulmonary edema, but anyway, yeah, that happens. And it was put down to, the concern was she had a recent flu-like illness. This is the echocardiogram, and this is the beauty of echocardiography, because you've only got to see this view and say whatever's happening, it's not the heart. Well, it's not a pump function, it's not a valvular function, it doesn't appear to be any cardiac dysfunction, and in fact what it was due to was supraventricular tachycardia, and on the background of a good ventricular contraction and normal chamber sizes on the echo, and this ECG was she given adenosine, and in fact the next thing you knew she was in sinus rhythm, and here she is with her baby in the NICU. So once again, it's not always an abnormal echocardiogram that's helpful. It's often a normal echocardiogram that gives you the confidence to take on other activities. Another case here, it's I always like this one because it brings in so many aspects of intensive care or acute care. It's a 35-year-old who in fact had been short of breath for 5 days. It was getting worse. She presented to the ED. They asked us to be involved, and she had a heart rate of 125, SATs of 88%, you can see there PO2 of 58, PCO2 of 24, and the systolic blood pressure is seen. Now, the difficulty there was is that the diagnosis, of course, had to be, pulmonary embolus had to be considered, and this is her chest X-ray. She's got clear lung fields. Once again, it's an AP. Can you comment on the cardiac size? Might be up a little, pretty hard to say. This is her echocardiogram, and I guess this says it all. It's the urgent echocardiogram. You do it immediately. In fact, you should probably do the echo before you do the ECG and the chest X-ray, because at the end of the day, that's going to tell you most of the stories in this situation. And you can see, in fact, on the top left-hand corner, that's just a comparison of a normal on the left. You can see, in fact, that the echocardiogram shows that the right ventricle is dilated, and once again, you've got a left ventricle that's somewhat squashed. It's more easily seen on the short parasternal view, where you have a very large right atrium. You have paradoxical septal motion of the ventricular septum. And once again, on the apical four-chamber view, you can see that the dilatation of the right ventricles, and the TR velocity is at 3.7, giving a gradient of 55 millimeters of mercury, which is pretty good for an acutely affected right ventricle. It's probably reaching the maximum of its ability to cope. Now, this is where it gets interesting, because we made the diagnosis of acute pulmonary embolus on this alone, and we could see it was pretty hard to think of any other condition that may have caused this scenario. But being good, how you say, condition doctors, we thought we better get some confirmation. So she was in the ICU. The question was, should she deliver now because she's hypoxic? Do we put her on heparin? Do we thrombolize her? Should we find out more? So the first thing, we rang the radiologist and said, why don't we do a CTPA? They said, no worries. We can do a CTPA, but do you realize that, in fact, she's 38 weeks. She's got very marked glandular development in her breasts, and just doing a single CT scan will increase her risk of a breast cancer in 15 years by so many percent. I thought, oh, okay, all right. Does she need it? And the answer was, no, she doesn't really need it. So we turned around and we went to the nuclear medicine. Why don't we do a VQ scan? They said, no worries, we can do a VQ scan. No, it won't affect the lady. But by the way, it does, the baby will get exposed to a lot of radioactive material, and you can't always rule out some subsequent result from that in years to come. So we thought, oh, well, let's do away with that as well. So in fact, we didn't do a CTPA or VQ scan. The diagnosis was made purely on the acute pulmonary embolus. We decided, in fact, we would run it close insofar that we would keep her in the ICU. If she had another large embolus, then we would consider thrombolysis. We didn't want to thrombolize in the expectation that she might basically have the need to deliver, and the bleeding would be difficult to control. On the other hand, if she was in extremis, then that might be the only step left up to us. We did talk to the vascular surgeon about a filter, but they were not keen on an IVC filter in a pregnant woman. They say more complications than usual occur. So we kept her on a heparin infusion. We had all the equipment to deliver the baby in the single room that we had her in. So if everything fell apart, we could do it all on the spot, and everybody was geared up. However, she remained stable on the heparin. We monitored for 2 weeks. She must have been 36 when she came in. We monitored her until 38 weeks. She was going to have a vaginal delivery, except she had a large uterine fibroids, and so she required cesarean section and then transferred to warfarin post-delivery. So, and I think we're coming up to our final case now. Postpartum cardiomyopathy. It's pretty hard to talk about obstetrical difficulties in the ICU without mentioning PPCM. Just to remind ourselves that it can occur post. The one on the left was picked up 6 weeks postpartum. The one on the right, as you can see there, is a woman that had a postpartum cardiomyopathy 25 years ago. She has an ejection fraction of around about 45%, and she leads a normal life. Peripartum cardiomyopathy, everybody jumps to the conclusion it's a peripartum cardiomyopathy. It's pretty rare. It's 1 in every 3,000 to 5,000 births. It's less than 1 of all cardiovascular events. It's important to remember that if you're going to use the definition, you have to have some criteria. And one is that it's development of heart failure within the last month of pregnancy. So that means from 36 weeks onwards. If you've got a woman with a heart failure at 32 weeks, then that actually falls out of the strict criteria for peripartum cardiomyopathy. It gets a bit tricky, of course. It can go to 5 months postpartum, and that's the other thing to remember. As I showed you with that woman with 6 weeks, that was picked up 6 weeks after the baby. The other thing is you have an absence of demonstrable heart disease before the last month of pregnancy, and your ejection fraction, by definition, has to be less than 45%. So remember those criteria, because with echocardiography, there are other things that occur as well. It's not always peripartum cardiomyopathy. Just remember that most of them occur in around the first week following delivery. And this is a study of 123. Most occur in the week post-delivery. And as you can see, the smattering from 37 weeks onward is the case. And you can see early, once again, they've pushed the definition there a bit to say if you get it early, you could have called it that. But you've still got a number of cases coming up at 2 months and 3 months, only a couple at 4 to 5 months. Okay, my last one. And this is called Lessons Learned Along the Journey. This is a 17-year-old with palpitations. She has frequent SVT. I saw her in my cardiology role at that stage and arranged for a radiofrequency ablation, and she had a reasonable result. She had a pregnancy in her early 20s, had a few rhythm problems, but really the pregnancy went okay. We obviously monitored her through the pregnancy. And she came to see me from time to time, but then in her early 30s, the ejection fraction, her left ventricular ejection fraction, started to reduce. And you think, well, why? And so we'll just have a look here over her pictures. And when you look more closely at this woman, she had a condition we knew nothing about 20 years ago. In fact, it only became an entity with a lot of echocardiography. But it turns out that, in fact, she had left ventricular non-compaction cardiomyopathy. And in that middle picture I show you there, sorry, I want to show you that middle one. You can see the muscular development. Sorry, this is just to show you the size of the left ventricle over here. She's got it 62 millimeters. You can see down towards the apex, she's got a lot of marked, irregular muscular fascicles that, and if you look very closely, and I'm not showing it in this, but we do it in another way with the color Doppler or with MRI, you will actually find a lot of blood channels between these muscular activities. And this one here, you can see that's right down towards her apex. She's got a lot of muscle, and there are various ways you have to be rather strict with the definition of left ventricular non-compaction cardiomyopathy, and you do with the MRI and do the amount of muscle compared to the amount of cavity space, and that's what she had. And to cut a long story short, since that time, when was that? Over the last few years, she's actually developed arrhythmias. She's had a defibrillator inserted as well, because these people die in their 30s from sudden death as a result of ventricular fibrillation. So just remember that it's an ongoing journey for these people, and the pregnancy is often just one part of their the journey. So if you do intensive care and you deal with pregnant women and you do echocardiography, I've only got two things to say. Keep an open mind and always perform an echocardiogram immediately. And that's my presentation. Thank you.
Thanks very, very much, Prof. You're probably preaching to the choir, telling us to do echoes and be terrified of,
that's true, yeah,
of sick pregnant women. I'm sure there are going to be a couple other questions. Can I just kick things off? Prof, the two things I want to ask about, first of all, was preeclampsia. And you're saying keep an open mind and always perform an echo. I'm thinking back to a time where I have not done an echo on a preeclamptic patient and it came back and bit me with worry about her developing peripartum cardiomyopathy. And I guess my two questions are, do you think we should be doing at least a focus study on everyone with preeclampsia? And then my second thing is, if we are seeing someone who's developing peripartum cardiomyopathy, about the use of bromocriptine, or do we just start with the simple stuff and then move on to bromocriptine later on in the day? So yeah, two questions, please.
Yeah, number one is, no, most women have, like 13% of women have preeclampsia, and they don't, and very, very few have heart problems. So unless you have some other clue about preeclampsia, like excessive breathlessness, I wouldn't automatically do an echo on these women. You can do, and if in doubt, do one, but as a general rule, I wouldn't do it if they're otherwise quite well.
Okay.
The second question, peripartum cardiomyopathy, yes. Two things is the peripartum cardiomyopathy has been much easier to deal with since the introduction of beta blockers. And in fact, in the 90s, 80s and 90s, a lot of these women would be automatically referred for heart transplantation. Whereas I've seen a number of these women now over the last 20 years, and with the introduction of carvedilol and the other beta blockers and the ACE inhibitors, most of them, it's very, very unusual. They end up in with a need for left ventricular assist devices or transplant. It doesn't mean to say it doesn't happen. It's just it's pretty unusual nowadays, because most of these women, if treated well, can often get a lot of recovery of function, and a lot of them go on to have other babies, which is another question. Back to the bromocriptine. Yes, the bromocriptine data is really quite fascinating. In fact, it's from a group in South Africa who did most of the work, and some Germans, to show that bromocriptine, when given early in peripartum cardiomyopathy, would appear to improve the outcome of those women. And I think the data is more anecdotal. There's been some studies done. There's been some double-blind studies done. The information points in the direction of it being useful. The only downside is that the woman doesn't lactate, and if she wants to breastfeed, they have to forego that. If they're very unwell with the peripartum cardiomyopathy, they often don't want to breastfeed anyway, so that's not a problem. So, but that's an issue you have to take up. Personally, yes, I've used it and I would use it again.
Thanks very much, Prof. Are there any other questions from anyone just in the last couple of minutes before we do some DDU questions?
Can you hear us?
Yes.
Yeah. So, Tony, what's general prognosis for these women? So how many of them get a reasonable recovery?
Are we talking peripartum cardiomyopathy?
Yes.
Most, the great majority will get a reasonable recovery. For example, at one end of the spectrum is the one I showed you, the woman who had a peripartum cardiomyopathy 25 years ago, happens to be a partner of a doctor, so it's probably the risk factor that she had. But if you can get the ejection fraction back to 45, 50%, then they're often just maintained on maybe a bit of ACE inhibitor or something. At the end of the spectrum, you're talking about women who end up having quite marked cardiac dysfunction. Not many. Majority will end up with, a lot of them, I would say roughly off the top of my head, a third would get back to normal LV contraction. A third would end up with reasonably quite livable LV contraction. And the other third might end up with the need for medication for a number of years. But it's much better than what you used to read about, because often these women used to appear at the later stages. They were in dire straits Whereas nowadays we would pick them up, and echocardiography plays a part here because you pick it up a lot earlier. How many people have I seen die from it in the last 10 years? I haven't seen one. No, I shouldn't say that, but I can't remember seeing one death recently from peripartum cardiomyopathy. I have seen one very close, though. A woman had a peripartum cardiomyopathy who did very well, and she came into our ICU 15 months after having the baby. And what she did have is she had a VF arrest at home. And fortunately, her husband started CPR, and she came into hospital and recovered well and had an AICD put in. So you can't always be sure. She was doing pretty well. She had an ejection fraction of about 45%, was thinking about having another baby, and out of the blue, she has a VF arrest. So there's always the unexpected can happen.
And does it recur with subsequent pregnancies?
That's always a big debate, because there's a lot of guidance about this, is that you can never guarantee a woman who's had a peripartum cardiomyopathy might not have another one. But the rules are generally that if your ejection fraction returns to normal, you're usually pretty safe. If your ejection fraction is above 45%, you discuss with the woman about the chances of that you're at a higher risk. And if you're willing to take the risk, then we will support you all the way through. But if we see a deterioration in your pregnancy, in your heart early in the pregnancy, we might talk about termination. If it occurs later in the pregnancy, the baby might have to be delivered early. But you've got to be aware that you can't rule out the fact that you can end up with a heart that's worse off than what you have now. Having said that, there's a lot of discussion that goes on between the woman, her partner, the obstetrician, the GP, and the cardiologist. And normally it works out. Some women just say, no way, I'm not going to have another baby. But most of the women would like another baby. And usually after 2 or 3 years, if they've been stable with an ejection fraction above 45%, even above 40, I would support it.
Prof, that's probably all the time we've got for you to speak about this. I just thank you very, very much again for a great talk, and just your experience and stories are legendary as always. Cheers, Prof.
Thanks very much, Sam. Thank you all. Goodbye all.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.